All right, we'll go ahead and get started. Welcome everybody to this afternoon's UNM Department of Psychiatry Grand Rounds. It's my pleasure to introduce Allison Gregg. She is a doctoral candidate in the Clinical Psychology program at UT Southwestern, and she's specializing in clinical neuropsychology. Her research interests focus on the neurocognitive impact of major depressive disorder, as well as the cognitive effects of antidepressant neuromodulation interventions. She is working with our co-investigator for many of our studies, Dr. Sean McClintock. And without further ado, Allison, it's all yours.
Perfect. Thank you, Dr. Abbott, and lovely to be here with you all today. Thank you for joining me this Friday. Let me see if I can figure out how to screen share. I would think this would be easier after 2 years of virtual presentations, but apparently it's just never going to get better. Okay. Let me see here. And so if I change it this way, are y'all just seeing the slides themselves and not presenter view? Is that correct?
Yes, that's perfect.
Fantastic. Thank you so much. So again, my name is Allison. I'm a doctoral candidate in clinical psychology at UT Southwestern over in Dallas, Texas. And today I'll be discussing with you the evolution of major depressive disorder subtypes. Before we get into everything, I don't have any disclosures to report. So starting with an outline of what we can expect to review today, we'll start with the history and development of MDD subtypes conceptually. And then a theme kind of running throughout this presentation will be some background on neurocognitive functioning with all of the major depressive disorder subtypes. So with that in mind, we'll kind of talk through some of the basics of evaluating neurocognitive functioning, some of the neurocognitive domains and the way that neuropsychologists evaluate those, just for some context. And then we'll get through to all the subtypes more specifically, discussing their corresponding neurocognitive and neurobiological features. And so the 5 subtypes we'll be focusing on today will be psychotic, treatment-resistant, melancholic, atypical, and then anxious depression. And then we'll conclude by discussing future research directions regarding the MDD subtypes. So beginning then with the history and development of the conceptualization of the subtypes themselves, it's important to, I think, provide some background into, why this is something that we're concerned about. So recent epidemiological study of MDD prevalence in the US was recently published in JAMA in 2018, and it found a 10.4% 12-month prevalence rate and then a 20.6% lifetime prevalence rate. And so we're starting to get a sense for the severity, frequency of MDD as kind of a disabling disorder in that way. And so most cases have been found to be moderate, so corresponding with 6 to 7 depressive symptoms, or severe with 8 to 9 symptoms present. Within that, it's really important to note how heterogeneous depression is as a disorder. We see that it can present clinically with a variety of different symptom clusters, or in this case, subtypes, due to the large number of potential symptom permutations. And so while we diagnose depression kind of as a single entity, MDD, it's interesting to know that there are 681 different combinations of symptoms that could potentially meet DSM criteria. So there can be a huge variety in terms of the presentation that we're seeing in this way. And so what we know about that is that the presentation of depression can then go on to differentially affect treatment course, relapse prevention, and then overall cognitive functioning as well. And so while we've seen that great attention has been given to the investigation of the clinical correlates of the subtypes, a lot of the aspects of their impact on neurocognitive function are unknown or understudied. And so we'll be kind of focusing on that throughout the presentation as well. For a little further background, this graphic is from the STAR-D study. And it's important to note here that depressive subtype and then specific clinical presentation has been shown to really differentially affect both course of illness, treatment, and then relapse prevention as well. And so this study, one of their outcomes was to kind of analyze factors that impacted remission rates. And what they ended up finding, and demographically at least, is that higher rates of remission were associated with those who were female, Caucasian, of a higher education level, were either married or cohabitated with a partner, those that were employed and insured as well. And then if we're looking at factors from the episode specifically, they found that those with a shorter current episode and then fewer concurrent general medical or psychiatric disorders were more likely to remit as well. Of particular note from this study, 33.5% of those that did reach remission in level 1 were found to then subsequently relapse during the follow-up period. So really what it seemed like is that for some 70% of patients, citalopram alone was really insufficient to sustain long-term remission in that way. And so we're kind of starting to see some implications regarding the treatment resistance that some patients experience with their depressive symptoms. And so again, here, just kind of really emphasizing the heterogeneity and depressive symptom presentation within MDD. There's this graphic from the SARDI study as well, which is really interesting. So the study itself had approximately 3,700 patients in the first treatment arm. And they noted 1,030 unique depression symptom profiles, with these being the most common 30 that appear within the study. And so this really just kind of emphasizes the broad variety of symptom presentations that we can see in this way. Okay, and so before we get into the nitty gritty of all the different subtypes themselves, it's interesting to take a look at historically what brought us to this point in terms of our current conceptualization of MDD subtypes. So beginning with the initial DSM publication all the way back in 1952, although really that isn't quite so far away when we really think about it, the DSM defined affective reactions as psychotic reactions with a primary severe disorder of mood, and they noted kind of a resultant disturbance of thought and behavior that occurred in consonance with the affect in this way. Manic depressive reactions were then introduced as well, marked by severe mood swings and then tendency for recurrence in that way. And so we kind of see kind of a very basic understanding of the introduction of depression at that point. Things shifted then a little bit further with publication of DSM-2 in 1968. Here we kind of see the precursor to melancholic depression introduced with this idea of involutional melancholia. And then manic depressive illness as well was detailed in the DSM-2. Interestingly, this concept of involutional melancholia was characterized by worry, agitation, and anxiety, and then severe insomnia. They noted that at that point, guilt and somatic preoccupations of sometimes delusional proportions were common. And then depressive episodes were characterized by depressed mood and then mental and motor retardation primarily at that point. DSM-3 is where we start to see really the main shift to the way we currently conceptualize subtypes. At that point in 1980 then, subtypes or subspecifiers were formally codified into the DSM and introduced into clinical practice at that point. And so here we see initially the psychotic subtype or the specifier with psychotic features, which constituted gross impairment in reality testing. So that would be delusions, hallucinations, or quote, depressive stupor that were assumed to be mood congruent unless specified as mood incongruent at that point. And so here we see this idea of mood congruent with depression being themes of personal inadequacy, guilt, disease, death, nihilism, or deserved punishment in this way. Again, with the DSM-3 in 1980, we have the melancholic specifier coming through, which they describe as loss of pleasure in almost all activities, and then a lack of reactivity to usually pleasurable stimuli, coupled by potentially distinct quality of depressed mood, worsening of depressive symptoms in the morning, early morning awakening, psychomotor agitation or retardation, and then potentially anorexia or excessive guilt as well. With publication of the DSM-3R, severity codes are then introduced. So then at that point, we see mild, moderate, and severe being introduced as potential severity markers with and without psychotic features at that point. And then DSM-4, we've kind of finally see this atypical specifier being introduced and really further cemented the inclusion of specifiers and subtypes within our conceptualization of depression. And so at that point then, atypical depression was kind of understood as depression with mood reactivity, also including some other potential symptoms like hypersomnia and lead paralysis. DSM-4-TR didn't really change our conceptualization of subtypes at that point. But things shifted then a little bit further, evolved further with publication of DSM-5 in 2013. We see this specifier with anxious distress being introduced, which was defined as the presence of at least two of the following during the majority of days of an MDE. So kind of feeling keyed up or tense, feeling unusually restless, difficulty concentrating because of worry, fear that something awful might happen, or feeling that the individual might lose control of himself or herself. And so it's kind of interesting just to kind of see how these kind of came out one by one in our conceptualization of depression in this way. Interestingly, you'll note compared to the 5 subtypes that we listed earlier, treatment-resistant depression is not currently codified in the DSM. And we'll discuss that a little bit further and kind of where the research stands on treatment-resistant depression as potentially being its own distinct subtype in this way. So here we can see kind of all the current specifiers available to us within the DSM-5. I've highlighted the ones that we'll be focusing on, and then, of course, treatment-resistant depression as well. We'll be speaking a little bit more about. It's interesting though, just to, I think, kind of conceptually think about this. So due to the current DSM classification of depressive presentations under one umbrella diagnosis, it somewhat leads to this assumption that depression is almost a single category. And we know that research does not necessarily support that conclusion and can at times produce negative treatment outcomes and things like that. And so what we see is this current structure in the DSM almost giving this false impression that patients who meet criteria for MDD should receive or might respond to the same treatment. Some people have kind of ended up with that interpretation of things. It's interesting to kind of think back to how this understanding came to be as well. Several decades ago, there was a widely quoted article in the journal Science that argued that there was really no basis for separate categories of depression. They all lie just only on a continuum of severity. And that model ended up becoming really highly influential and was adopted by the DSM-3 at that point and continues to influence the conceptualization of depression in the DSM-5 currently, where melancholia and psychotic depression are modifiers rather than separate diagnoses or separately conceptualized in that way. And so, as we're thinking about that, we'll kind of talk through why there might be some potential issues with that conceptualization of depression as, a homogeneous diagnosis with just a severity continuum, as opposed to maybe having some more distinct presentations available to us as well. So before we go through and discuss those different subtypes and some of their corresponding features, we'll kind of talk through some background in the way neurocognitive function is being evaluated, since, as we noted earlier, that's going to kind of distinguish a lot of these depressive subtypes in this way. And so I want to acknowledge that y'all might have very, different backgrounds in this. This might be review for some of y'all, but bear with me. Hopefully there's some utility in it. So we'll start out with kind of an explanation of the major neurocognitive domains and then how they're typically evaluated by neuropsychologists as well. So starting with some of the most basic motor skills, motor functioning in that way, typically can be evaluated with the groove pegboard. If you can tell at all from this really horribly quality image here, the pegs have a round side and then a squared off side, and what the patient has to do is rotate them to, in essence, just get them into the pegboard as quickly as possible. And so we might have them do this with both their dominant and non-dominant hand, kind of compare them, see if speed-wise their fine motor skills are at the capacity we might expect. It also can indicate some lateralization as well if there's differences in, the abilities for dominant and non-dominant hands according to what we might expect as well. Then we have processing speed. So how quickly an individual can process and synthesize information presented to them. This also kind of has some impacts our visual scanning speed rather as well. Perhaps the best, most simplistic example of this is Trails A, which I believe we probably have all seen at some point or another, where we're just asking the individual to kind of connect the numbers in increasing order as quickly as they can. Another way we might evaluate this more thoroughly is with the WAIS sport coding subtest. And the WAIS is the Wechsler Adult Intelligence Scale, so how we generate IQ scores. So with that coding subtest, what the individual is asked to do, there will be rows of numbers in essence, and then kind of a key at the top where each number is presented with a corresponding unique symbol. And they just have to go through and as quickly as they can draw out the symbols with the numbers listed below. And so again, just kind of getting at how quickly they're able to do that. Also kind of pulling for some incidental learning in that way as well, if they're able to synthesize that more efficiently and abstract patterns from that. Then we have the neurocognitive domain of attention. So we kind of think about that as concentrating on one thing and ignoring other things that aren't of interest to us at that moment. Again, we have the digit span test, which is in the waist, but we see in some other mental status exams as well. So how many digits can an individual kind of keep in their attentional span at that point and repeat back to you? Another test that is frequently used for evaluating attention is the continuous performance task, which again, you can see this really lovely image of here on the right as well. It's a pretty basic, I guess, test and concept, but it goes on for a while in duration. And so we're looking at how long an individual can sustain their attention. And they will be shown different letters, as you can kind of see, and then maybe be asked to click the mouse on the letter X. And so it's almost painful in length sometimes, but you're really trying to see, well, if we're making an individual sustain attention for quite a while, can they do that? If they get distracted, can they reorient to the task at hand in this way? So then getting up to some domains of increasing complexity then rather, we have verbal learning and memory, which can look a lot of different ways in the way we evaluate it, starting with something like the California Verbal Learning Test, which is a list learning task where across 5 trials, an individual is asked to reflect back an increasing number of words. There's immediate recall where they repeat them back to you immediately, and then delayed recall as well. So we're looking to see if we give this individual 30 minutes to consolidate that information in their memory, are they able to do so? Sometimes we have recognition trials as well. So looking to see if you give them options for words that might have been presented to them earlier, can they identify which ones they had previously heard? Other verbal learning and memory, we have paragraph learning or story memory as well. So verbal material of increasing length and complexity in that way also. Similarly, then we have visual learning and memory. So most clearly exemplified here with the Ray Oster's complex figure test. So this is an interesting one too, because it kind of pulls for that visuospatial perception too. So you can see some visual neglect if it comes through in something like this also, and then, fine motor skills if they can draw it. But in essence, they're asked to copy this image, do an immediate recall, then 3 minutes later, remember this drawing and draw it out to the best of their ability, and then 30 minutes after the fact as well. This one generally also is accompanied with the recognition trial, so if they see different elements of this, so perhaps this little bowling ball looking aspect there, if they see that, can they circle that and identify that that's something that was on that original image? And the way we kind of separate those out into immediate, delayed, and recognition tasks as well is really helpful for the way we understand memory, right? So an individual can maybe consolidate something and put it into their memory, but have issues with retrieval, right? We see that particularly with certain issues. And so that's why we might ask about recognition memory, because maybe they can't voluntarily regurgitate that information, but they'll recognize it. And so that tells us something about their learning. So they learn that information, just maybe that memory component is a little bit more impaired in that way. Moving on then to executive function, one of the more higher order cognitive functioning domains that we have. You can kind of think about this as planning, organization, cognitive flexibility, and set shifting. An example of this is Trails B, where an individual is then alternating between numbers and letters in increasing order, so kind of that set shifting component. Another example is Stroop, which you can see here on the right, where we would ask an individual to first read out the words themselves in that first column, then name the color of the ink as in the third column, and pardon me, as in the second and fourth, name the color of the ink that the words are printed in and ignore the letter or the word itself. So kind of getting at that inhibition thing. And then another example for evaluating executive function might be the Wisconsin card sorting test, where an individual is asked to match different cards to a few different options based on different matching potential rules that could work, and they have to integrate feedback from the examiner as well. So it's kind of looking at that novel problem solving test, cognitive flexibility, and then ability to integrate feedback as well. Okay, so then thinking about scoring. So an individual's raw scores can tell us a lot if we know what to do with that information. However, we see an extra dimension of meaning coming through with the comparison to normative data of individual scores. And so Normative data, by that, we mean that when tests are created, the testing company will generally administer them to a demographically representative sample of the country that they're created for. And so we can then take individuals' raw scores and compare them in essence to a population and see, well, is this what we would expect from an individual? Is this performance average? Is it not average? Where kind of in that continuum of performance is it falling in that way? And so from that, we can kind of get an understanding of how severe the individual's deficits in that test may or may not be, or how well they might have excelled in a test as well, in that way. And so we can kind of conceptualize these tests or these test scores in different ways too. We have the Z-score, which is kind of looking at standard deviations from the mean in that way, percentile rate. So for example, an individual might score better than 90% of all individuals who've taken that test if they're in the 90th percentile. We also have T-scores where mean is 50, scaled score where the mean is 10, and then standard score where the mean is 100, which is, I guess, most commonly exemplified by like an IQ score, for example, in that way. And so here, just to kind of illustrate this a little bit further, we have the normal curve. And of course, not every test will be kind of normally distributed in this way, but this will give us an idea of, I guess, just what you can expect from an individual's potential performance, where the bulk of individuals will be scoring in that average range. So within one standard deviation in either direction, we then start to kind of get an understanding that if they're scoring fewer standard deviations lower, oh, that's looking, maybe a little bit impaired or deficient in that way, as opposed to the other way around. Maybe if they're scoring really highly, two standard deviations above, and they're looking superior in that kind of a range. And then we have different descriptors to kind of conceptualize that in this way. But you can see as well this kind of conversion that can take place down below, where we can kind of equate the different scores to kind of understand as thoroughly as possible, where does an individual score fall within the population as well. And notably, what we will do for a lot of these comparisons to normative data is compare along age demographics and then education demographics, since we know those are two of the things that most profoundly impact neurocognitive function. And so what we can really, in essence, do is say, well, okay, for this individual, if they achieve this score, are they where that we would expect someone of their age and of their educational attainment? Are they in line with that? Or are they maybe a little bit better, maybe looking a little bit more impaired? And so kind of comparing them in essence to a healthy control in that way. And so once we are kind of able to score all of these different tests looking at these different neurocognitive domains, the end goal is to really kind of establish a neurocognitive profile. And so what do we mean by neurocognitive profile in that way? Well, what we mean by that is attempting to understand the way these disorders kind of are impacting all the different aspects of neurocognitive functioning. And so what we know is that these different disorders, or in this case, different subtypes of major depressive disorder, kind of create these unique blueprints of cognitive functioning in this way. So in the same way we might have, say, a psychological or clinical profile for someone with like an antisocial personality disorder, for example, we might know things that we would expect from their presentation. We might expect them to be manipulative of others, maybe have some trouble with the law due to the lack of regard for societal rules, maybe have exemplified some impulsivity and things like that. Similarly, we'll have expectations for what we would anticipate from their neurocognitive profile, or patterns that we would expect based on cognitive functioning from certain disorders in this way. And so, what we can do then is kind of see the implications for this across a multitude of different domains. And so why do we care about the neurocognitive profile? Well, it can impact diagnosis, is one thing to note. So from the neurocognitive profile, we can start to take a look, is this looking more neurological in cause? Is it looking more psychiatric? We can also get into more of the forensic realm, but can detect malingering as well. Is there secondary gain involved? Is the person's performance looking very atypical for even the presentation they're claiming in this way? And so we see it impacting diagnosis. More importantly, though, the neurocognitive impact of a disorder really impacts the functional impairment, their prognosis, and individuals' treatment response as well, and different treatment recommendations. And so consider, for example, someone with a profound memory impairment, we start to think, okay, well, they're going to have trouble maybe remembering conversations on the day-to-day. That's going to impact their quality of life quite significantly. You might then also be worried that maybe they'll put something on the stove and forget to turn the stove off. So then starting to have some concerns for safety in that way as well. If we're thinking about, treatment and prognosis as well, we might be worried they might forget to take their medications. And so that's going to impact medication adherence. So we can kind of abstract out the true implications for this neurocognitive profile in that way as well. So now that we've had the kind of easy breezy introduction into neurocognitive assessment, let's then start to apply that to the different MDD subtypes and also kind of take a look at some of the neurobiological correlates of the subtypes as well. And so we'll kind of go through in order of, bulk of research and evidence, kind of starting with psychotic depression, since this is potentially the most studied subtype of the bunch that we'll look at today. And so like we kind of touched on earlier, psychotic depression, or the specifier of psychotic depression, is a marker of major depressive disorder severity rather than a specific subtype delineation itself within the DSM. And so psychotic symptoms within the context of depression usually end up consisting of auditory or visual hallucinations or delusions that center around those themes of, for example, guilt, nihilism, things like that. And so psychotic depression in this way is reported to be biologically and then also neurocognitively distinct from non-psychotic depression. Various studies have really suggested that adults diagnosed with psychotic depression tend to be older. They tend to have poorer premorbid functioning, longer major depressive episode length, and then also greater likelihood of future psychotic depressive episodes, as well as poorer prognosis. So we see this impacting a lot of aspects of their functioning in this way. Then looking at the neurobiology of psychotic depression, we see that it might be associated with structural and functional brain abnormalities, such as amplified ventricle to brain ratio, enhanced parietal region atrophy, reductions to cortical thickness, as well as altered regional cerebral blood flow, and increased HPA axis activity. And so here's a good kind of exemplification of that as well from this article that compared healthy control participants to patients with remitted psychotic depression. And what they found is that those with remitted psychotic depression demonstrated significant reductions in cortical thickness in 5 structural networks. And so those structural networks were the insular limbic, occipitotemporal, temporal, parahippocampal limbic, and then the inferior frontal temporal networks as well. And so you can kind of see those highlighted in the different shades of blue in this image here. So then thinking about the way kind of that neurobiology might then inform the neurocognitive impairment, we can start to consider that neurocognitive profile in a way. And so evidence suggests that differences in neurocognitive function between the subtypes particularly affect psychotic depression. And we see this impairment in executive function, attention, and verbal memory most profoundly. Perhaps what I find to be the most interesting component of this is that the cognitive profile ends up really closely resembling that of schizophrenia. And I'll show you this image that really well exemplifies this. But here we can see in the study healthy control subjects in the green, those who are non-psychotically depressed in the purple, and then patients with psychotic depression in the pink and schizophrenia in the orange. And so this really kind of profoundly illustrates the degree to which the neurocognitive profile in patients with psychotic depression really mirrors that as those patients with schizophrenia, because you really see similar impairment in all the same domains, just not to quite the same severity. And so it really kind of highlights the impact of those psychotic symptoms. And again, shows the connection between the heterogeneous presentation of depression and that differential impact on neurocognitive function as well. So then we'll kind of go through and compare the profiles of all of these different subtypes as we go through, but then looking at psychotic depression, we're really seeing this kind of diffuse impact in neurocognitive functioning in this way. And then I saw a question in the chat, let me see. Why would the non-psychotic depression patients have increased functions in some of the cognitive domains? Yeah, that's a good question here. We can go back here. I don't have a specific answer for you right now. If I had to speculate, I would say it could potentially have to do with some compensatory processes in that way. But again, I would like to speak more to the specific study, but they didn't really kind of touch on that difference then between their healthy comparison subjects and the non-psychotically depressed patients in that way. Oh, absolutely. I wish I could give you a better answer, but I don't remember off the top of my head from this publication. Okay. Then looking at treatment-resistant depression, again, not currently in the DSM, but something that we're becoming increasingly interested in due to the prevalence rate. So in recent meta-analysis, it's been estimated that between 30 to 46% of individuals with MDD fail to fully respond to treatment in that way. And so we kind of saw that with the STAR-D trial as well. 67% of patients with depression cumulatively remitted, but that leaves a large portion who then did not, or then remitted or were found to relapse in later trials of the study also. And so the interesting thing we kind of get into with treatment-resistant depression that has kind of, I think, inhibited a lack of inhibited consensus in this way is the multiple methods that have existed historically for both defining and then measuring treatment resistance. That kind of variability in the methods has led to difficulty, I think, comparing results in treatment-resistant depression studies. And interestingly, although various risk factors for TRD have been suggested, few have really been consistently supported, likely due to that kind of inconsistency in definition in this way as well. Although kind of recently we see this suggested definition of lack of remission after 6 weeks of adequate treatment. One of the issues that kind of comes out with this as we abstract that further out is what does it mean if an individual is treatment resistant for one treatment versus treatment resistant for 3 or 4 versus experiencing treatment resistance for 1 year versus 5. So kind of abstracting that a little bit further, I think, additionally complicates that picture in this way. So in looking at the neurobiology of treatment-resistant depression, we see some degree of inconsistency regarding the neurobiology within the subtype specifically. However, we have some really interesting data so far. So one is kind of pointing to this idea of limbic cortical network dysfunction. And they're kind of saying that this network dysfunction is combined with compensatory processes, and that might explain the heterogeneity of depressive symptoms that are observed clinically, as well as the variations in pre-treatment scan patterns that were kind of found in that study as well. Kind of abstracting that out further, then we see implications for remission rates then in that way, based on those network dysfunction and then compensatory processes. Functional brain imaging has also been used to study patients with depression, and abnormalities have been described in the frontal and to a lesser extent limbic and paralimbic and subcortical regions as well, although there's been some variability across studies in that way. What I find to be the most interesting is that there's been metabolic activity differences kind of detected in the rostral cingulate that ends up discriminating eventual responders from non-responders, and kind of suggests that that area may function as almost a bridge linking dorsal and ventral pathways that are necessary for the integrative processes of mood, motor, autonomic, and then cognitive behaviors in this way. And we see all of those being disrupted in depression. And so it really kind of highlights the potential impact of that metabolic activity in the rostral cingulate. So kind of looking at that more specifically on imaging, we see this kind of overlapped PET and MRI superimposition, and you can kind of see the Z-scores here on the right. So in the cool tones, we see that kind of correlating with hypometabolism, and then in the warm tones, the hypermetabolism. And so here what we see is based on the 3 groups of depressed patients compared with healthy controls, cingulate hypometabolism characterized the non-responder group in contrast to hypermetabolism seen in the eventual treatment responders. So it really did seem to kind of discriminate the degree of treatment response that was seen in that group. Interestingly as well, this is the seminal paper that then led Mayberg to pursue this area as a region of interest for deep brain stimulation as well. So if we go on to consider the neurocognitive features of treatment-resistant depression, again, somewhat conflicting evidence that we find, as with everything in the literature, apparently with treatment-resistant depression. But we do see the most evidence for deficits in executive function, processing speed, and memory. And so one study in particular found that patients with treatment-resistant depression performed worse on visuospatial and executive function tasks. And then also this complex figure memory as well. And they kind of hypothesized that the difference between the groups was due to increased white matter lesions and atrophy that they found in the non-responders relative to the responders in that same study. Okay. So then again, if we kind of look to compare to psychotic depression in this way, we see that same kind of visual memory and then also verbal learning and memory impairment kind of being pulled through. Same with executive function deficits, which is one of the kind of hallmark impairments that we would expect from a patient who's depressed. But again, it's looking like a very distinct profile. You know, we're seeing impairment in the processing speed where we didn't with those with psychotic depression. I'm not seeing the same impairment in depression or in attention in this way. So really kind of highlights the very distinct presentations neurocognitively as well. Okay. So then we'll move on to melancholic depression. So research suggests that between 25 to 30% of individuals diagnosed with MDD meet diagnostic criteria for the melancholic subtype. And so it is the most clinically studied depressive subtype, although we don't see that kind of pulling through for the neurocognitive side of things, unfortunately. But it's associated with neurovegetative symptoms, including decreased appetite and weight, early morning awakening, psychomotor retardation, as well as excessive guilt, profound despondency, and diurnal variation. And so we see that diurnal variation being kind of the hallmark symptom distinguishing melancholic depression in this way. And that kind of correlates with the mood worsening that we tend to see in the morning as well. And so the findings suggest that melancholic depressive symptoms, interestingly, vary across major depressive episodes. And so kind of highlights this intra-individual depressive symptom shifting in a way. So that's to say that melancholic symptoms may persist or then fluctuate across different episodes of depression that an individual experiences as well. So then looking at the neurobiology of melancholic depression, findings suggest decreased metabolism in the inferior frontal lobes and then decreased regional cerebral blood flow in the left anterior cingulate and then left dorsolateral prefrontal cortex. You can kind of see that a little bit further in this image here, where we see regions of gray and white matter volume change in patients with melancholic depression. And so across that top row in the box marked A there, we see the gray matter volume reductions in the left posterior insular cortex. And then across that bottom row, the box labeled B, we see the white matter volume increases in the upper brainstem tegmentum in this way. Okay, and so then looking at the neurocognitive features of melancholic depression, we see that the neurocognitive profile of melancholic depression was found to consist of impairment in the domains of primarily visuospatial memory. Interestingly, within this visual spatial memory impairment, we did see changes in recognition memory ability. And like I might have touched on earlier, with recognition memory, that tends to be kind of the most preserved aspect of memory functioning in that way. So to see that impairment is really interesting. We also see executive function deficits with some evidence for additional impairments in motor skills as well. And so the studies reviewed kind of highlight that melancholic depression coincides with this, what they call like widespread cognitive deficits across most neuropsychological domains when compared to healthy controls. And so what you'll see is I marked primarily the ones here, executive function, visual memory, motor skills, where we see the most significant impairments. They talk about these global changes where it looks somewhat worse to healthy controls, but again, it's not meeting criteria for like true impairment. So these are the domains where we see true impairment, although there is potentially some suggestion that there might be lower baseline neurocognitive functioning. So again, you know, some degree of consistency in terms of which domains we are seeing any degree of impairment on, but again, a distinct profile in comparison to the other two. So just really continues to hammer home how distinct these are in presentation, at least neurocognitively. Moving on then to atypical depression. Again, about a 15 to 30% prevalence rate that can really vary by study you look at. Diagnostically, atypical depression is characterized by mood reactivity, which is this capacity to be cheered up when presented with positive events. And so DSM-5 notes that the mood may become then euthymic for even extended periods of time, potentially, if, quote, external circumstances remain favorable. So there's this degree of ability to experience response to pleasurable stimuli in this way. It also kind of is potentially comprised of weight gain or appetite increase, hypersomnia, leaden paralysis, and then interpersonal rejection sensitivity as well. Interesting to note here that patients with atypical depression have substantial comorbidity with a variety of anxiety disorders. For example, social phobia was found to be quite comorbid, as well as eating disorders and then substance-related disorders as well. And so if you think that all of those might affect clinical outcomes as well. Compared to non-atypical depression, atypical depression typically has earlier age of onset, tends to present then with longer depressive episodes, and then has distinct personality pathology and biological traits as well. And so kind of, if we're thinking of this mood reactivity as being the hallmark symptom of atypical depression, it's kind of then become theorized that it's almost on this bipolar spectrum in that way as well. And you can kind of see that historically here. I won't, belabor the point by reading through all of these, but if you kind of look through historically the patterns here, it's interesting to kind of look back to the initial Weston Daily publication in 1959, which noticed a distinct sample of adult patients with MDD that responded better to MAOIs, and initially provided kind of then the first characterization of atypical depression. Later then in, I think it was 1988 or 1984, with Leibowitz and colleagues, then operationalized atypical depression as depression with mood reactivity, kind of then gradually evolving then over time to we see then in 2007, the Pittsburgh group kind of conceptualized it almost as a bipolar disorder spectrum in that way and a soft bipolar spectrum. So interesting to kind of just note the evolution of theory behind atypical depression in this way. At least for me, I find it very curious. So then going on to look at the neurobiology of atypical depression, we see corresponding changes in HPA axis activity, so hypoactive HPA axis activity in that way. Also implicated is inflammation. So those with atypical depression were found to generally have greater levels of inflammation as compared to those without atypical depression and healthy controls as well. And then also different pro-inflammatory cytokine patterns as well. Another study then compared brain perfusion by using PET scans as well, and found that patients with atypical depression compared to those melancholic or control subjects had increased frontal, temporal, and then parietal perfusion differences as well, which is interesting to note. So then neurocognitive features, I wish I had something to tell you about this one, but unfortunately there's a huge dearth of information regarding the neurocognitive functioning of atypical depression. So again, unfortunately nothing to add to our lovely table here. So moving on to anxious depression, which anxious depression, if we're thinking clinically, is distinct from other MDD subtypes in that the symptom profile includes a lot of somatic concerns. So like that increased heart rate, shortness of breath, dry mouth, excessive sweating, in addition to elements of this detachment that we see, as well as psychological distress. And so compared to those with melancholic depression, individuals with anxious depression have higher rates of attempted suicide, higher rates of alcohol abuse, and then personality pathology rates as well. So interesting to kind of think about the implications for prognosis in that way and just kind of appreciate the severity of some of those comorbidities, especially when we think about the increased frequency of suicidality in that way. And so the STARDY study that we mentioned earlier found that sociodemographic variables also differed between those with and without anxious depression. They found that those with anxious depression were more likely to be older, more likely to be unemployed, as well as to have lower levels of education as well. So then looking at the neurobiology of anxious depression, we see primarily a deficit in 1A subtype serotonin receptors. Then moving on to the neurocognitive features of anxious depression, research has demonstrated that comorbid anxiety and depression relative to depression alone significantly decrease learning and memory in this way for both verbal and visual information. Interestingly, here we see that the degree of neurocognitive impairment is highly correlated with the anxiety symptom severity as opposed to the depressive symptom severity in this way. So it's almost looking to be that the anxiety symptom severity is more predictive of what we might see on evaluation in that way. So here then we're seeing, again, primarily this verbal learning and visual memory impairment in this way. So wrapping up with kind of a summary of everything we've discussed today and some areas for future research as well. We kind of talked through all of the 5 different subtypes listed here: psychotic, treatment resistant, melancholic, atypical, and anxious. Noting as well that treatment resistant, while not formally codified in the DSM, there is ample evidence to suggest it as a kind of distinct subtype in this way. We talked through the different neurocognitive impairment as well of these subtypes, kind of highlighting just how much they do differentially impact neurocognitive functioning. Psychotic depression, again, really closely mirrored that of schizophrenia and its neurocognitive profile. We see some consistencies coming through in terms of frequency of memory impairment across subtypes as well. But again, the heterogeneity in clinical presentation is very closely mirrored in the heterogeneity and neurocognitive impairment that we see as well. And so just really important to consider the way that these differentially impact cognition in this way. And we discussed earlier as well, the impact for then functional impact or functional impairment, quality of life, other concerns that really have many implications for the patient. If we're going to think then about future research directions, a lot of research that we discussed is really kind of pointing towards potentially including treatment-resistant depression as an MDD subtype based on its distinct, clinical features as well as neurocognitive and neurobiological as well. We also kind of need to continue to explore the subtype delineation itself, looking at those clinical and neurobiological correlates as well as the neurocognitive impact. Like we saw for atypical depression, there is an absolute dearth of research, unfortunately, looking at that. And we do see that really impacting a lot of aspects of the patient's functioning in that way. Also, kind of going back to that initial slide, thinking about the history of, major depressive disorder diagnostic classification this way, we see potentially the way that we're conceptualizing depression isn't quite reflected in what we're seeing in like the patient's presentations. Maybe conceptualizing it as this homogeneous diagnosis that really only varies by severity isn't quite capturing a lot of the patterns that we're seeing in that way. And so then if you're going to take away anything from this presentation, just maybe consider the way the subtype presentation can differentially impact an individual's prognosis, treatment options, as well as their neurocognitive profile as well. And so with that, I will open things up for questions.
Allison, thank you for a fantastic presentation. If it's okay, I'll start off with just a question, and it's okay to speculate. But my question is based on what we often see with depressed individuals and effort. How would effort impact this neurocognitive profile? Would you speculate it would be a separate category, or would it kind of adversely affect one domain more than another?
That's a really fantastic question, and something that has been really looked at closely, because I think, like you're potentially alluding to, we see effort kind of impacting all those domains, right? So if a patient isn't putting forth their full effort, it's really difficult to get an accurate understanding of their neurocognitive functioning. We see certain response style patterns tend to come through with depression. So what comes to mind is with, some of these forced choice questions where you ask a patient to choose yes or no, you kind of see this I don't know response bias where they might just kind of, try to kick the ball down the road a little bit. That kind of tends to hint towards some lower effort in that way. And so at that point, assessment will kind of lean on, hopefully, the neuropsychologist trying to engage the patient the best they can, and then kind of looking at some of those validity indicators to see, well, if the patient isn't putting forth their best effort, what does that mean for the patterns that we're seeing?
Thank you for that. I think we have one question in the chat box. Given the relationship with inflammation that you pointed out, would you be most likely to see someone with chronic pain have a atypical depression compared to other subtypes?
That's a really interesting question. I actually haven't thought about that. I would love to see if that's been researched. I kind of want to go do a little lit search now, but I'm hesitant to really conclude any degree of causative factor with that inflammation. If it's secondary to the depression, who knows? But I think to your point, and we do see some comorbidity with the chronic pain. I could see potentially that being the case, but yeah, that's a really interesting question. Thank you for that.
Any other questions? Okay. I think we are, if we have no further questions, I think we are going to conclude with this Grand Rounds presentation. Okay. Allison, thank you again for a really informative presentation. And thank you everybody for joining us this Friday afternoon.
Perfect. I'll stop sharing and thank you all so much. I appreciate it.